My name's Leslie Suen. I'm an assistant professor of medicine in the Division of General Internal Medicine at San Francisco General Hospital. I'm also presenting with Damian Peterson today, who is a pharmacist in the San Francisco Department of Public Health, and then Sarah Rosenwohl-Mack, who's assistant professor in family and community medicine. So today we are doing buprenorphine inductions, traditional low dose, direct to inject, and everything in between. And these are all methods to start buprenorphine that have been relatively popularized in the past few years. And we thought it'd be a good idea to present and have people ask any questions that they have, both based on the literature, our personal clinical experience, and any other topics that people may want to discuss. So our learning objectives today are first to describe the pharmacologic properties of buprenorphine that inform clinical decision-making for induction strategies, including its partial agonist activity, its high receptor affinity, and pharmacokinetics that are very specific to each formulation. We will compare the evidence-based buprenorphine induction approaches for outpatient settings, where I work predominantly, including large dose, low dose overlap, and direct to inject approaches, and identify really appropriate patient selection criteria for each of these methods, and then evaluate the clinical applications, benefits, limitations of direct to inject buprenorphine, which is the most recent and popularized method of starting buprenorphine as of late, including patient selection considerations, implementation challenges, especially for first and second generation long-acting injectable products. So first, I'm going to turn it to Damian to discuss buprenorphine pharmacology.
All right. So to begin with, why do we even care about buprenorphine in general? It's a medication that's used to treat opioid use disorder, and oh, sorry,
I was told to let people into the meeting
room. It's shown to have almost a 50% reduction in all-cause mortality compared to no treatment, and there's not really many medications that have that same sort of impact. In part, something that contributes to why bup has this reduction in all-cause mortality is the fact that it's a partial mu-opioid agonist. It also does have activity at other opioid receptors. It's an antagonist at the kappa. It binds to ORL1. But for most purposes, the mu-opioid activity is what is really important here. And because it's a partial agonist on that mu-opioid receptor, it has a ceiling effect on respiratory depression and sedation, which confers an amount of overdose protection. So if we're looking here at this graph, we have a full agonist such as either methadone or fentanyl. And as we increase the dose, we see an increase in the opioid effect. And contrast that with buprenorphine, which is a partial agonist. Initially, when you increase the dose, you do have this increased effect, but eventually you hit a point where you hit this plateau. And despite how many milligrams of bup you give somebody, you're not going to further decrease their respiratory drive. The trade-off here is because it's a partial agonist, starting buprenorphine is hard. When people are using full agonists like heroin or fentanyl and their body is used to that environment, to all of a sudden go from having all of your receptors fully activated by heroin and fentanyl to having your receptors now activated only part of the way is going to be experienced as a very rapid negative experience that we refer to as precipitated withdrawal. And so as opposed to just entering withdrawal when somebody ceases using opioids, which is a gradual process where they start to feel worse and worse as time goes on, this one, you just very abruptly go through this syndrome and are just feeling horrible pretty quickly after you take your dose of bup. This here is a picture that sort of depicts what's going on when we precipitate withdrawal. So we have the receptors fully bound to our pink-colored full agonist opioids. And if you introduce buprenorphine in too large of a quantity at once, because it has such a high binding affinity for these receptors and a slow dissociation constant, so it doesn't like to get off of the receptors once it's on it, it will outcompete the full agonist opioid, replace it, and you'll have this sudden precipitous decrease in the amount of activation of your opioid receptor. And we know that when we have two different drugs that are competing for the same receptor, it's really going to be a function of their different potency or affinities, as well as the concentrations of the medications. And so this is just demonstrating that, if you take a 16 milligram dose of buprenorphine, you're going to displace significantly more fentanyl than somebody who takes a 4 milligram dose. But any dose of buprenorphine is going to displace some amount of fentanyl. Another thing that makes buprenorphine pretty hard to start, and Leslie will go into this more when she's speaking in her part, but back in the days of heroin and pills being the predominant opioid, those are all hydrophilic molecules. And so they have pretty simple kinetics where, you inhale your heroin, it goes to the lungs, into the bloodstream, has its effects as it travels throughout the body, and then eventually reaches the liver, you metabolize it, and it's gone. And so it makes it relatively easy to have a sense of like, if I wait this amount of time, like more than 12 hours, enough heroin will have left my body to where it'll be safe for me to start buprenorphine because enough of those receptors no longer have heroin on it. With fentanyl, it's extremely lipophilic, has a large volume of distribution because of this, and we have to think about the three-compartment model in order to really appreciate how different fentanyl is. And so here we have in the yellow, the poorly vascularized adipose tissue or the fatty tissues. In the blue, the highly vascularized tissues. And in the red is the plasma. And so compared to heroin where, you smoke something or inhale it, it goes to the plasma, has its effects, gets metabolized and cleared. As you consume fentanyl chronically, it begins to accumulate in the fat stores. And what that causes to happen is as you clear the fentanyl from your plasma, the equilibrium shifts the fentanyl that is stored in your other areas like your muscle, but also adipose tissue, and replenishes an amount of fentanyl into the plasma. And so in order to truly get the fentanyl out of your body, you have to go through this process where you're clearing from plasma, it redistributes, and then it clears from plasma again, it further redistributes, and it takes quite a while for somebody's body to actually have cleared enough fentanyl for it to be safe. And while this is going on, fentanyl's also it's not in a uniform concentration throughout the body. And so while somebody might have sufficient opioids in their periphery, they might have a lower exposure in their central opioid receptors. And it makes it hard to gauge withdrawal and when somebody's in enough withdrawal because they might be feeling like these opioid withdrawal symptoms because their central receptors are, sorry, need water. Because their central receptors don't have opioids, but the peripheral ones might have plenty. And it makes it difficult to judge when it's actually been enough time. So while with heroin, we could wait 12 hours and feel pretty safe starting somebody on buprenorphine. With fentanyl, it's really like 36, 48 hours plus. I've had people precipitate withdrawal like many days without using fentanyl, just because of how long it sits around in the body. And so we're back. So like we said earlier, if you take a large dose of buprenorphine, it's going to displace a lot of fentanyl, and you're going to cause that rapid shift. And let's say fentanyl has the receptors 100% activated if we assign like 60% to buprenorphine. Going from 100 to 60% all at once feels horrible. So thinking back to, smaller doses of buprenorphine displace less fentanyl. When you change the formulation and the route of administration of a drug, it is going to change the way that it behaves in the body. And with these newer injectables, due to their favorable pharmacokinetics, it allows us a new way to start people on buprenorphine without having to have them go as long without using, or in some of our protocols that we'll talk about, you don't have to go any amount of time without using it all to start it. And that's because these injections, as compared to sublingual tablets or films, when you take a sublingual tablet or film, on this graph here, it's in like the lighter gray shade, you have a peak concentration at about 2 hours because you get that entire dose absorbed all at once. And so all of that gets into your bloodstream. That amount of buprenorphine is what the receptors are exposed to, and it's able to displace large quantities of fentanyl. But with these injections, they slowly release in the body. Over 24 hours is their peak time. And so it allows us to displace tiny amounts of fentanyl as time goes on. So rather than going from like 100% to 60% when taking that sublingual dose, we might go from like 100% to 97%. And these small incremental changes are going to be a lot more tolerable than having to go from that large 100 to 60. And so those sorts of things, the difference in kinetics between the sublingual and the LAI, allow us to have some creative ways to get people onto buprenorphine. And just for some more background, there's two different companies that are making these long-acting injectable buprenorphine products. The original one that held market for the longest amount of time was Sublocade, and recently, past 2 years, we now have Brixadi available in America. And it's specifically the Brixadi weekly injection that gives us that 24-hour time to peak. And that allows us to do all of this. And then just comparison for the two for background information. When there was competition between these two companies, it really forced the original one to update a lot of its protocols to remain competitive. And so now they both have sublingual start protocol changes. They can both don't need to be refrigerated. They both can be given in multiple sites. But prior to this competition on the market, it was pretty restrictive and could only give it in the abdomen. But yeah. When somebody's on maintenance doses, either one of these might be a great option, but when we're starting somebody out, which is the most difficult part, we're really leaning on that Brixadi weekly injection. And then next, we're going to have Leslie talking about outpatient PUP initiations.
Okay, thank you, Damian. I just wanted to pause briefly for questions, just to see if anybody had any questions for Damian before we move on to outpatient starts. Feel free to unmute yourselves. I can't see the chat, unfortunately. Nothing there. Nothing? Okay. Okay, we can keep moving. So I think that we didn't mention this earlier during the introduction, but Damian, Sarah, and I all have clinical experience starting buprenorphine in the outpatient setting. So usually in clinics. Damian also is one of our main pharmacists who leads the program in San Francisco Department of Public Health, where he actually delivers medication, buprenorphine medication, to people in their single room occupancy room, so their SROs. And so we thought it might be helpful to actually go through what are the most common ways that people start buprenorphine in the outpatient setting. And these three methods are the most common ways that we do this in San Francisco. There is the traditional method, which Damian mentioned, is how we used to start buprenorphine back in the days of heroin, waiting for severe withdrawal, usually 24 to 48 hours, and then starting, substantial doses of buprenorphine. There's low dose overlap inductions, also known as buprenorphine microdose colloquially, where we start tiny doses of buprenorphine, usually about 0.5 milligrams, and escalate those doses slowly over several days. And then there's the newest kid on the block, which is the direct-to-inject, which Damian mentioned, where we directly provide a long-acting injectable buprenorphine, usually the weekly second-generation injectable, the Brixadi, and do a series of injections over 48 to 72 hours without any sublingual doses. And so we can talk a little bit more in depth about each of these strategies. So the traditional, I think most people are maybe in this audience the most familiar with. And these, again, this was the way that we used to do it in the days of heroin. We would tell people who were dependent on opioids, and we still do this a lot for people who are using prescription opioids for chronic pain because they have a lot lower opioid tolerance than, say, somebody who's using fentanyl. And so I think this is still very much a method that we use commonly, again, for people who are either using heroin or using prescription opioids. So what we'll tell people to do is usually stop your opioid and wait for moderate to severe withdrawal. Usually we go by COWS scores. I like to wait for a COWS of, if depending on the opioid, a COWS of at least 13 for someone who's using fentanyl, and then maybe COWS of 8 to 12 if someone using heroin or pills. And usually it takes a while for people, a certain amount of period for people to get to that COWS score. For fentanyl, people who are using fentanyl, it takes about 48 plus hours. They will feel terrible in those 48 hours, but usually it won't be safe to actually start buprenorphine until they've waited sufficiently long. And then it's a lot shorter period of time for heroin and prescription opioid pills, usually about, I'd say, 8 to 24 hours for each of those. Yeah.
Just say a little bit about what COWS is, because I
Yeah.
think we have some basic scientists on.
Absolutely. I'm so glad you asked. So COWS stands for Clinical Opioid Withdrawal Scale, and it is a scale that we use clinically to assess the level of withdrawal for people. And so a lot of people will use the MD Calc app and go and actually look at the scores. And you look at people's different aspects of their physical exam. So you look at their pupil size, their heart rate, whether or not they have goose flesh skin, nausea, vomiting, and it goes through a list of symptoms that are associated with how severe their withdrawal is. And the score is usually given to assess that severity. And so, as I mentioned, we usually wait for somebody in the traditional method to have a certain level of COW score, usually at least 8 if you're doing heroin and pills, or at least 13 if you're someone who's using fentanyl. So once they've reached that threshold, the buprenorphine in the traditional method is usually a medium to substantial dose, about 8 milligrams. And then, or we can do even higher if you're feeling bold, to 16 milligrams if they're in severe withdrawal. And then you give additional buprenorphine as needed. And the idea is that the buprenorphine immediately treats that severe withdrawal because their receptors are completely empty. And that buprenorphine will immediately make them feel better. The benefit of this method is that it immediately helps control symptoms, and people can get onto buprenorphine, a good maintenance dose of 16 milligrams or higher, much faster compared to the other methods. The major con that people can maybe guess is that people have to wait until they are in that severe withdrawal, and that can be very distressing, uncomfortable, and just unacceptable for a lot of patients, especially who are using fentanyl and that level of withdrawal, especially if you're unhoused, facing a lot of structural challenges, can be very, very almost asking the impossible of people. It is particularly, as I mentioned, good for people who are using prescription pills or heroin, just because the withdrawal syndrome doesn't tend to be as intense or severe. And as we mentioned, a lot of people don't feel like they can actually tolerate that level of severe withdrawal, and therefore the other methods are sometimes much more appealing to them. Another way to look at this, and I credit this to Aisha Appa, Dr. Appa, who is in the division of who is one of our colleagues in infectious diseases. And so the way to think about it is when you're in traditional induction, you wait until your receptors are empty, you have sufficient opioid withdrawal, and then you start the buprenorphine, which is the orange squares, and the buprenorphine attaches to the receptors and you feel moderately comfortable. You go from opioid withdrawal to comfortable relatively quickly. And so how has fentanyl changed how we start buprenorphine? As Damian mentioned, heroin and fentanyl are completely different because fentanyl remains in the body longer. receptors are still occupied by fentanyl despite ongoing lack of use. And therefore, patients who have not used in a while may still experience precipitated withdrawal after starting buprenorphine. And then it also, chronic fentanyl use can also lead to development of higher opioid tolerance and more severe withdrawal symptoms. And then also fentanyl has a
So
much higher,
much.
oh, excuse me, a much higher binding affinity to receptors. And so fentanyl can compete with buprenorphine at the mu opioid receptor, displacing existing buprenorphine. So it's kind of like what I describe to patients is like sometimes it feels like a battle going inside your brain between fentanyl and buprenorphine, and they're just pushing each other off. What this looks like is, someone who is feeling in clinical withdrawal, but they have a lot of fentanyl on the receptors. Still, because it stays longer in the body, buprenorphine coming in can push off that fentanyl, and it can lead to feeling even worse or worse precipitated opioid withdrawal. The outpatient low dose overlap methods were popularized, I think, about in around 2020, and especially in San Francisco. So a lot of patients will still use this method, and we offer it and do it all the time in San Francisco across our various substance use disorder clinics, including Bridge Clinic at San Francisco General, and then OBIC, the outpatient buprenorphine induction clinic where I work. And the idea is that you have almost, we give people a bubble pack of medications. We say, here's 7 days of medication, and each day you're going to increase the dose of buprenorphine that you get until you get to a maintenance dose. And through, most importantly, the part that is appealing to people is that it minimizes that risk of precipitated withdrawal, though there is some risk still. And also, people usually will still use their opioid while they're going through this. So there's not that period of you have to stop entirely and wait until severe withdrawal. You can gradually start buprenorphine in this way. And this is on the left. This is actually the bubble pack that we give people. You can see it's like very, day 1, 2, 3. Each row is a different day. We mark, morning, noon, evening, and bedtime. And then we also spell out the instructions on top. And we really try to make it as clear as possible for people. And the idea is that, as I mentioned, people can continue to use their opioids throughout, whether that's heroin, fentanyl, and people tend to find that a little more appealing than having to stop entirely. The buprenorphine, we usually start about a quarter of a tab. So that's, and these are 2 milligram tabs. So on day 1, we usually start with 0.25 milligrams, and they dissolve it in their tongue one time. Day 2, they do that twice. So a total of 0.5 milligrams in day 2. And then we keep escalating that dose each day. The benefit is that they don't have to stop using that opioid again because people may not feel ready to stop using their opioid at the time of starting initiation. I've had patients tell me, I kind of just want to dip my toe in the water and I'm not yet ready to give up my fentanyl, or I just kind of want to see how buprenorphine feels. And so it allows some sort of gradual transition into recovery without that hard stop of you are going to quit fentanyl right now. That people may find a little bit more appealing. The other benefit is, it does have a lower risk of precipitated withdrawal than traditional induction methods that we talked about. The major sort of con is that people will still feel mild discomfort throughout the process. And that is just because, it can be very challenging to continuing your fentanyl use throughout, and a lot of people don't know, or even, as clinicians, we don't really know how much to advise people, how much to use their fentanyl, just because the drug supply is so unpredictable. And then also, the buprenorphine may be displacing, as I mentioned, some of the fentanyl throughout the process, and that can cause a lot of discomfort for people. So I describe it as having like a little bit of a mild cold throughout the entire 7 days, but is a much more tolerable and less severe than, having to go through severe withdrawal or precipitated withdrawal. And then for people who don't like injections or can't wait 48 hours for that severe withdrawal to kick in, this is a really good option. In reality, when we look at our actual retention and completion rates, It's only about 30% of people will actually complete this. And the reason being that it's usually 7 days of taking a medication that is slowly working. You're kind of feeling crappy the entire time. And so a lot of people aren't actually able to go from day 1 through 7 successfully. And again, looking at, describing how this is happening at the receptor level, someone who is, their green trapezoid is their full agonist opioid, such as fentanyl or heroin. And they, on day 0, they're quite comfortable. They start to introduce small doses of buprenorphine that displace a little bit of the agonist, and so they feel a little bit uncomfortable, starting from days 1 to 2, and then their buprenorphine dose is increasing. So from 3 to 5, they're also still feeling a little bit uncomfortable, but that buprenorphine is starting to occupy more receptors in their brain. And then finally, on days 17 to 14, that buprenorphine has fully been introduced, and the fentanyl is still around, but it's definitely by no means dominating the picture anymore. I will mention that the formulation depends on the setting that you're in. So buprenorphine has many different formulations, as you may know. There are the films and the tablets. There are also buccal formulations where you place inside the cheek and let it absorb. There's also patches, and there's also intravenous buprenorphine. All of these formulations we use pretty interchangeably in the inpatient setting. They all have their different uses. And I'm happy to go through that more if anybody's interested, because we're focusing mostly on outpatient talks. Really, practically speaking, only the films and the tablets are available in the outpatient setting. You can, for patients with opioid use disorder, you can, if your patient has chronic pain, it is FDA approved to use buccal or buprenorphine patches to start buprenorphine for chronic pain. However, if your patient does not have chronic pain, then you're either having to rely on the films and tablets, or you can also apply for a prior authorization to get these formulations. And this is sort of, again, how we start this using the tablets. We coined this the Howard Street method because our pharmacy, CBHS, Community Behavioral Health Services Pharmacy, is on Howard Street in San Francisco. And again, so on day 1, we start with 0.5 milligrams. Day 2, we have a 0.5 milligrams in the morning and the evening. We do that again on day 3 in the morning. We do a half tab in the afternoon and a half tab in the evening. And we do that just to reduce any medical or medication waste, which the DEA tracks very closely. And then day 4, they're up to 1 milligram or 2 milligrams in the morning, 2 milligrams in the evening for a total of 4 milligrams. Day 5, they're 3 milligrams in the morning and evening for a total of 6. And then and by day 7, they're usually doing 4 milligrams 4 times a day or 8 milligrams 3 times a day for a total maintenance dose of 16 to 24 milligrams, or even higher if someone has a high tolerance, such as using fentanyl. And so we mentioned when we looked at the actual outcomes, this was a study that we did across Bridge Clinic and OBIC, 2 clinics in San Francisco, where we did an observational study of 126 patients who attempted 175 low-dose attempts. And we noted that there are high rates of co-occurring methamphetamine and fentanyl use in unstable housing. And these are patients with opioid use disorder with or without chronic pain. As I mentioned, 2/3 returned for follow-up. However, only 1/3 of people completed initiation, which we defined as picking up a refill prescription with a maintenance dose of buprenorphine. We have 2 different options of initiations using the low dose. We have a 4-day option and a 7-day option. I only mentioned the 7-day, but happy to go in the 4-day if people are interested. But there was really no difference that we saw in completion between these 2 methods. And then at 28 days, only 22%, so 1 in 5 people remained in treatment. So again, I think that this is a very appealing option and is definitely a tool in our tool belt. However, in reality, it can be quite difficult for people to actually complete this protocol. And we also found that people who had multiple attempts or had unstable housing were also less likely to complete their initiation. And then in terms of, looking at the entire literature of low dose initiation, when you compare hospital settings, it does seem that doing this in the hospital tends to be much more successful than doing it in the outpatient setting. So I mentioned in our study, we found about 34% completed initiation, 22% was retained at 28 days. When you look at, there are about 4 or 5 hospital studies about a sample size of anywhere from, 10 to 60 people. Their completion rates are actually much higher, about 68 to 85%, and their retention at 1 month tends to be also higher, about 46 to 66%. And there's a lot of reasoning, we're not sure why, but it seems like the hospital may be a much more controlled setting. They have much more predictable supply of opioids. They're using, hydromorphone and oxycodone instead of, street fentanyl. And so many different factors may be at play. And then also, the social and physical environment of the hospital encourages and expects abstinence in the way that someone, living who is either unhoused or living in an SRO, being surrounded by drug use may not have that difference in setting, may be impacting our rates of success. So I think, barriers to consider in the outpatient setting are lack of stable housing, lack of stable storage for medications, challenging social situations and relationships that we really should be thinking about when we're starting someone on buprenorphine in the clinic, because they're not just, starting medication in a vacuum, they're going home and doing this rather challenging medication process in the milieu of their social situations. Oops. Okay, I'm going to move it to Sarah now to do direct to inject.
There's a question.
Oh, yeah, go ahead.
About indications for bupe in the treatment of acute pain.
Oh, interesting. Can whoever asked that question, would you be able to unmute and ask and tell us more about that question?
Hi, everybody. This is Marilyn Basinski. I'm a clinical nurse specialist in pain management at UCSF. And this is a question that comes up quite a bit, and specifically in the emergency department, where we are confronting pain management in older adults and worried about giving them too much opioid and wondering if there would be an opportunity to give lower doses of buprenorphine to help treat their pain.
That is a great, wonderful question. I think, like all clinical scenarios, it depends. I will first headline this with saying that this has not been studied. So buprenorphine has not been studied for acute pain indications. Usually acute pain, the standard of care is to provide full agonist, short-acting opioids like oxycodone, especially if someone is coming in with a fall, such as a hip fracture or any sort of fracture. But I definitely it's hard because in our older populations, that can lead to a lot of adverse events or adverse effects, especially if they continue that opioid long term. I think that it really would depend on the clinical situation. So if someone is coming in with a fracture, and this, varies with clinical person to person. I'd be curious to hear what Sarah and Damian would say. But I think that I would still rely on our short-acting opioids because we know that in an opioid naive person, which our older adults tend to be, it's much easier to titrate a short-acting oxycodone or hydromorphone, such as Dilaudid, i.e. Dilaudid, into titrating their pain control. Buprenorphine is a little bit harder because it is a much higher morphine milliequivalent than oxycodone or hydromorphone. And so it is a little bit harder to titrate. It does have a longer half-life. And so I would be a little bit hesitant unless there were really clinical factors that were pushing me towards starting buprenorphine, such as a history of opioid use disorder in the past or a history of some other substance use disorder like alcohol use disorder that was making me really, really really concerned about the patient in the long-term chronic, someone who is maybe going to have adverse events if they start opioids. But if it was just, a patient who was older coming in with a fall, who needed short acting, a short course of opioids, I would still rely on our tried and true opioids of oxycodone and other agents. I don't know if you all feel differently. Okay. Great. Okay. Sarah and Damian are nodding. Okay, great. Does that answer your question, Marilyn?
Yes, thank you so much for the dialogue on that. Just a really interesting topic. And I was going to say something, but I totally forgot what was my next point. But anyway, I'll think of it. I'll put it in the chat. Thank
Great. Awesome. Thank you. Okay, I'll turn it to Sarah.
Hi, I'm going to talk a little bit about direct to inject and why this has been such a exciting and sort of promising new way to start buprenorphine in the outpatient. I want to start by recapping what Leslie and Damian both said, right? So this traditional start is not a tenable option for most of our patients in the outpatient setting who use fentanyl. In fact, I don't even think of it as something on the table. If I'm working in a clinic, I have a patient come in, they tell me that they're using a gram of fentanyl a day, which is sort of a middle of the road amount for many of our patients. It doesn't even occur to me that they might be able to tolerate waiting 48 hours and then starting. And part of that, it's confusing because fentanyl, an individual dose of fentanyl wears off very quickly. But for the reasons that Damien explained, fentanyl over time, because of its lipophilicity and its accumulation, sticks around for so long that it's not safe to start bupe until, for fentanyl, it's been something like 48 hours. But people feel severe withdrawal so much sooner, right? Because an individual dose of fentanyl wears off quickly. And that's why people who use fentanyl typically use, every few hours throughout the day. And that severe withdrawal is bad. People are sweating and throwing up and going to the emergency room. Like it can be really, really severe. So that's off the table almost always in an outpatient setting. And microdosing ends up being effectively off the table, or at least not an ideal option, because it's really hard, as Leslie was describing, to take a medicine 4 times a day. I once was given an antibiotic that I had to take 3 times a day, and I'm a stably housed person with a phone and a timer and a coherent life, and it was really hard to actually remember all those doses. And I think how much harder it would be if I were unhoused, didn't really know when it was day or night, didn't have a safe place to store my medicine. Also, the medicine kind of made me feel bad. Also, when I use drugs, I forget to take the medicine. It's astonishing to me that it works at all for our folks for whom it does. Um, and again, highlighting what Leslie was saying about this is in the outpatient setting. In the inpatient setting, our options are different. And this does work really well in the inpatient setting. But so direct to inject. The I'll start here actually for a sec. So the idea of direct to inject, as both Leslie and Damian described, is essentially it is a way to start someone on bupe slowly without them having to tolerate a lot of withdrawal. The way that I describe it to patients who have familiarity with a microdose, or the way that I describe it to trainees when I'm teaching, is that it's kind of like it's like a um, automatic microdose that up titrates itself automatically. So when Damien, let me forgive me as I go back to the slide. So when you look here at this, at the slope of the CAM 2038, that was the early name for what is now called a weekly dose of Brixadi, you see that it rises slowly over the first 8 hours, and then sort of even more slowly over 12 to 24 before peaking around 24 hours. It does that on its own. You don't have to take those tiny little doses of bupe. You give someone the injection, and then it does the work itself, and that's really appealing for patients, and it's really cool that it works. Forgive me as I go back to our slides. So there are 2 different protocols, and we'll talk about it a little more about the way that we use this medicine. But I want to highlight how, in addition to how exciting this is, kind of how new it is. The very first study on direct-to-inject buprenorphine initiation was in 2024. It was less than 2 years ago in the emergency room setting. The first study, like looking to see if this was feasible. The first time anyone looked to see if this could be done in the outpatient setting was work that our group did in 2025. And sort of we've continued to do a lot of work in this area, and other groups are working in this area as well now, but this is new and exciting. And our patients are also excited, which is one of the coolest things. So a little bit of the nuts and bolts. There are these 2 injection protocols and 3 injection protocols. They're similar but different. The idea of the 2 injection protocol is that you're going to give somebody a weekly injection, and then 24 hours later, you're going to give them a monthly injection. It could also be like up to a few days after that. It doesn't have to be exactly 24 hours later. And in order to do that, somebody needs to stop using opioids and be in mild withdrawal. For a lot of our patients, that's fine. People tell you, yeah, I can wait 6 hours from when I last used. Like, it's not fun, but I can do it. I can't wait that 48 hours you told me about, but I can wait 6 hours. For those people, this works really well. For the 3 injection protocol, which as you can see here is 2 different weekly injections and then a monthly injection, 2 lower dose weekly injections. This is kind of like an even sort of more expanded version of the microdose protocol in injection form than the 2-day one is. And that one, people usually continue to use their full agonist opioids, their fentanyl or their heroin, in the same way that when they're doing the sublingual microdose protocol, they use their and continue to use fentanyl or heroin. And people can do this protocol having just used 2 minutes before. Like there's no kind of waiting period required to decrease the risk of withdrawal. This is really exciting in part because it's really well tolerated. We have done this now for hundreds of patients, and most people have mild to moderate withdrawal. They have sort of a rocky-ish 24 hours. Some people feel nothing, and something like 10% of people have severe withdrawal, which is a meaningful number of people who do poorly, but is much lower than something like traditional starts, which generally go terribly and is not far off from microdose starts. The cons, this, I will say, as a clinician who kind of works in a bunch of outpatient settings and can offer and provide all of these, my default is now direct to inject, as long as somebody's okay with injections. Because the retention data is better, because people tolerate it better, because due to some health system infrastructure changes and advocacy work, we now have really good access to these injections. This is where I'm going to default to, as long as somebody's okay with injections. There are some people who will tell you, I will never have an injection, either because it reminds them of when they used to shoot up heroin or because they're scared of needles. Those people, this is not going to be an option. But for folks who are open to injections, this is the default option in an outpatient setting now, I would say. This is the slide that Damian was showing before, comparing the reason why this works again, which is that in contrast to a sublingual dose of buprenorphine, where you have this sharp rise soon after administration, and that sharp rise reflects a sharp increase in buprenorphine that kicks fentanyl off the receptors, causing precipitated withdrawal, you have this more gradual increase. There are multiple formulations of the injectable medicine. Damian spoke about these a little bit, that have varying half-lives and varying time to peak. This is really important because as we've been doing more and more of this work and kind of publishing more on it and talking more about it, we've had folks wonder, can we just do a monthly injection? Like, instead of starting with a weekly injection and then doing a monthly injection 24 hours later, can I just give someone a monthly shot of bupe and be done? And there's patients who've asked us for that, who've been on the injection before, and they say, can I just get the Sublocade? Can I just get like one injection and be done? The answer almost always, unfortunately, is no. And the reason for that is because both Sublocade and monthly Brixadi have a shorter time to peak than weekly Brixadi. So for Sublocade, there's this initial burst in the first 1 to 3 hours for complicated reasons involving the like carrier gel matrix that the medication is stored in. And then for monthly Brixadi, it's something like 6 to 10 hours afterwards. And that's still too close, we have found, to a sublingual dose, where you have that kind of rapid rate of rise, versus Brixadi weekly, which is this kind of slower rise over 24 hours. So it's really the like time to peak, or that rate of rise, that we think influences how much withdrawal people experience when buprenorphine is knocking fentanyl off receptors. Comes in a bunch of different doses. And this is a little bit more nitty-gritty for folks who are doing this clinically, and I'm happy to answer more questions about how we choose what dose to use. But one of the things, if there are folks on this call who are familiar with prescribing sublingual buprenorphine, there are sort of ready conversions to the weekly and monthly equivalents. And so you can, if you know that your patient is someone who you think this would be somebody who would need 18 to 24 milligrams of bupe sublingually, you can have a sense of what weekly or monthly injection they might ultimately need. Okay, 2 and 3 day direct to inject. So the similarities of these protocols are that you're doing 1 to 2 weekly injections of Brixadi followed by a monthly injection. Mild to moderate withdrawal is common. And what that means, we're doing qualitative work as well, and I'll get into that a little more later. But what this means is that most people say something like, that felt kind of rough, but it was sure better than the other time I tried to start. Or I thought I might have to go use, but actually like I fell asleep and it was okay. Or I was like pretty nauseous and kind of unhappy, but like I got through it. And so it's meaningful withdrawal that a lot of people are experiencing, and it's typically more mild than either kind of precipitated withdrawal or even just the withdrawal that people have when they are sort of forced to go longer without opioids because they're incarcerated or something else happens that stops their access to opioids. Most people do really well. Most people like this. From a clinician perspective, the reason why I'm so excited about this work, sort of both in research and clinically, is that because I have patients come to me now and say, oh, hey, my friend started the shot. Can I do that? And having people seeking treatment is for this really, really, really devastating illness, is such an exciting thing. And people are telling their friends that it's going well, and that's cool. Differences, we talked about a 2 or 3 day injection protocol, the criteria to start with regards to how long you wait from the last time you used, and how we counsel people about ongoing fentanyl or heroin use. And I can get into the logistics, kind of the nitty-gritty of that more later if that is of interest. So diving now a little bit more into 2 day protocols and 3 day protocols. The 2 day protocol, we talked about, excuse me, we want someone to be in mild withdrawal before they start. A COWS score of 4 is a very mild amount of opioid withdrawal. In 6 to 12 hours, at least, since the last time that they used. We typically give 24 milligrams is the dose of the injection that is most commonly studied. And so that is often our default dose. This is because the largest trials around this and the only prospective trial of this came out of the emergency room setting where that was the only dose that they used. We don't know because there isn't research on this, but we suspect that higher doses of the weekly injection might be slightly more likely to cause bupe-associated withdrawal or precipitated withdrawal or whatever you want to call this kind of state of withdrawal where bupe is knocking fentanyl off receptors. And we think that's probably true because we know that higher doses of sublingual opioids are associated with higher rates of precipitated withdrawal. We don't know this, and it may not apply as well for injectable bupe, where you do have that much slower slope. And the thing we're always weighing is, on the one hand, maybe a lower dose is less likely to cause severe withdrawal, but on the other hand, a higher dose is more likely to get somebody what they need to feel better, right? Like if you use opioids and you are now on a lot of bupe, maybe you feel great. And maybe if you're on a little bupe, you feel bad because you still have this kind of opioid debt, this amount of opioids that your receptors are used to seeing that you're not getting. So my patient who uses fentanyl, who traditionally would have needed 32 milligrams of sublingual bupe a day, if I give them an injection that only gives them the equivalent of 12 milligrams, they're going to still feel really bad. So that's the kind of balance that we weigh based on our anticipation, and that has resulted in somewhat hand-wavy but evidence-informed, though not fully supported guidance of doing something like a 16 milligram dose for folks who use heroin and a 24 milligram dose for folks who use fentanyl. The one other cool thing about the weekly formulation and this kind of time to peak category is that once the medicine has peaked, you are receiving this sublingual equivalent. So to be more specific, if I give someone a 24 milligram injection of weekly Brixadi, 24 hours later, their body has a serum level of 12 to 16 milligrams sublingual bupe. So that means that I can give them as much bupe as I want, and there's no way I'm going to precipitate them because they have plenty of bupe on board in their receptors. And what that means, and we were the first folks to study this, and we're really excited about it, is that you can safely give somebody a monthly dose of buprenorphine 24 hours after a weekly dose. And so you see someone, you give them a shot, the next day you give them another shot, now they're covered for a month. That's really, really, really exciting, especially when you consider the instability of many folks' lives, their difficulty in accessing care, the profound overdose protection that especially higher doses of injectable bupe can give. So that is the basis for this counseling here, which is 24 hours or more after a weekly dose of Brixadi that's 16 milligrams or greater, you can give a monthly injection. You can also give it beyond just that first day, right? Like if I gave that first injection on a Friday, if I gave somebody 16 milligrams on a Friday, I could still give them the monthly on a Monday. It doesn't have to be the Saturday. We have these evidence informed based on the sort of pharmacokinetic curves of anticipated serum levels of buprenorphine in the body after a single dose of a weekly injection to inform when we think it's still safe to give another injection, with the idea of that being you want there to still be enough bupe in the body, right? That you can give them more bupe without risking precipitating them, especially if they've had interim fentanyl or heroin use. And so after a 24 or 32 milligram dose, we're comfortable giving someone a monthly injection up to a week out. After a 16 milligram dose, we typically wouldn't give it more than 4 days out. The other thing that's tricky about this 2-day injection protocol is that we do recommend, in addition to having people wait 6 to 12 hours from the last time they used, We recommend that if they can, at all possibly, they wait another 6 hours after the injection before they use. We give people clonidine and hydroxyzine and ondansetron and loperamide and sort of symptomatic medications to help the process. And sometimes in particularly complicated situations, we'll trial 1 or 2 doses of a low-dose benzo. And the idea of this is that basically the reason why we have people wait those like 6 hours from the last time they used before they get the injection is because I want them to have like some amount of withdrawal, have some amount of fentanyl that's already left the receptors, right? That's the point. If I give you an injection and you use fentanyl 1 hour later, you've sort of reset the clock on the time since last use. Now you're getting the injection at the same time as you last used. You have a higher risk, we think, of precipitated withdrawal. And anecdotally, we've borne that out. We've seen that borne out. This is such a new area of research. In the outpatient world, we only have retrospective cohort studies and and very limited kind of data even at that. But that's what we've seen kind of anecdotally, and it makes pharmacologic sense. I'm going to talk about the 3-day protocol, and then I'm going to pause for questions, and then we'll continue into what the work that we've been doing more specifically for our PARC grant. The 3-day protocol, so this is a 3-injection protocol, more accurately. This is a protocol developed by folks in Seattle, a team led by Richard Waters, and his colleagues. And this is a cool protocol. It's the protocol that doesn't require a time since last use. And the idea is, like the sublingual microdose protocol, you are giving people a small amount of bupe that increases over time, and people continue to use typically their heroin or fentanyl during the first few days. This works great. We initially had hopes that this would cause less withdrawal, and it doesn't. It causes the exact same amount of withdrawal. Everyone still also has mild to moderate withdrawal. Some people have severe, some people have none, in really almost the exact same rates, at least among our patient population. And we're sort of right now, part of the work we're doing for this project is helping us kind of do a retrospective analysis of 2-day versus 3-day injection protocols and seeing what the outcomes are. But it has the profound advantage of it's an option for people who say, I really can't wait from the last time I used. Like, I can't wait 6 hours. What are you talking about? Like, there's no way. So it's really, really helpful for that. The con is really just the downside to this one is really just a 3-injection process extends a process that people feel mildly poorly during and requires a more complicated schedule. You need to be able to find someone 3 days in a row, or they need to be able to find you 3 days in a row, or 3 days over a relatively short amount of time. There's a kind of complicated algorithm for what to do if they get the first dose but miss the second, if they get the first and second but miss the third, and that's based again on our understanding of sort of the pharmacokinetic curves of like where the bupe serum levels are in the body and when you still have enough bupe to safely give you more. That we have adapted a graph by Richard Waters' team in Seattle to make a kind of clinical. We're putting out a lot of protocols to help support clinicians across the health network in the Department of Public Health, and this was part of that effort. A couple more points on DTI before I turn it back to Leslie. One, we already talked about this. We talked about the reason why you can't give someone sublingual bupe until it's been at least 24 hours after a weekly dose, because that's when you know you have enough bupe in your body. The other thing that we have found difficult at times is when people have used a lot of methadone. Methadone, like fentanyl, is a complicated drug with complicated metabolism, but in some ways it's even more complicated because at steady state, or when you've had 4 or 5 doses daily in a row, it goes through multiple metabolic pathways that Damian could speak more about intelligently than I could. But we do advise clinicians who are implementing these protocols to seek sort of expert advice if you are trying to help someone start buprenorphine who has taken a bunch of methadone recently. A lot of people get methadone on the street, and that can then be when they're not able to access other things, and that can then complicate the process. We spoke about this already, which is the reason why you can't just do this with a monthly injection right off the bat. This is pretty well illustrated in this graph, where you see that the monthly injections kind of peak around 6 hours here and then decrease. That time to peak is too fast for people to tolerate this. And then just briefly, like as Damian mentioned, there are different considerations about whether you decide to, after the weekly injection, whether you give someone a monthly dose of Sublocade or Brixadi. Sublocade is, and apologies that I'm using brand names, but for long-acting injectable bupe, sometimes it helps for clarity. Sublocade is a more uncomfortable injection that forms a depot under the skin. Brixadi is less uncomfortable and doesn't form a depot under the skin, and so the experience of the injection is different. But Sublocade has a much longer half-life, a much longer tail, rather, which means that you can give people follow-up injections even if they've been missing for weeks from your care. It has better overdose prevention, and provides a higher serum level of buprenorphine, and that can be really desirable for a lot of folks. I am going to end before we move on to our preliminary findings by talking about the other reason why we're so excited about this, which is, as Leslie described, the study that Leslie authored and led looked at our patients in our system and what experience they had. And when you look at as she mentioned, about 30% make it through their kind of microdose starts, and then something like 20% are still on bupe a month later. And in these not these exact same patients, though some of them are the same, in this population of our kind of public setting patients, we have something like 68% of people in our earlier data still on bupe a month later. And that doesn't necessarily reflect ongoing engagement every single day for that month, because what it has meant is that somebody has made an early decision to opt into a monthly injection that has covered them. But we do find that more than 40% of people are still taking buprenorphine 3 months out, which is tremendous and much better than any other retention data that we have in our system. So early signals, but that's exciting. I'm going to turn it back to Leslie to talk a little bit about. Oh, yes. Sorry, I can't see any of those. Please.
You can come off mute or I can read them.
Yeah, if you want to unmute yourself, if you had a question. I can't see the chat. I'm so sorry.
Say it if I'm here. How do you counsel prepare patients for the potential unpredictable experience in outpatient settings? That's the first one.
It's a really good question. We have, and I can share this via email afterwards if it's helpful. We do have sort of patient handouts that we've developed to counsel people on what to expect after these injections. We counsel sort of both about like what to expect. You may feel some mild withdrawal. We're prescribing you these medicines you can take that will help with your symptoms. Here's a number to call if the medicines aren't working or you need more support. And we talk about, we counsel about what we expect people to do or would advise them to do with regards to ongoing fentanyl or heroin use. And so this goes back to what I was describing with the 2 injection protocol, where we tell people, we recommend, if you can, not using fentanyl for 6 hours after this injection. That's going to give you your best shot at not having much withdrawal. If you need to use, you need to use, but this is what we've generally seen most helpful. And then for the 3 injection protocol, we tell people that because the amounts of bupe are small and really building up slowly, most people do find that they still need to use fentanyl or heroin throughout, and that's to be expected. And we counsel sort of along those lines.
The other question is, what have you found helpful in terms of dose and frequency for patients on greater than 24 milligrams of sublingual buprenorphine?
Yeah. So when
Are you, yeah, can you repeat that? I don't know if the fans can hear.
Thank you. Alex was repeating a question about what doses or frequency have you found most helpful for people on more than 24 milligrams of sublingual bupe? This is a talk more about bupe initiation than retention on bupe, but it's a really good question about how to switch people who are on sublingual bupe to injectable bupe, or even people who aren't yet on bupe, but who you anticipate might well need more than 24 milligrams. Those are I'm going to hope that I included this chart earlier. Forgive me while I scroll back. I did not, sorry. So there is a chart that I can also send out and share that shows the sublingual equivalents of the different doses of Sublocade. So people who need more than 24 milligrams of sublingual bupe will likely not be successfully maintained on monthly injections ongoing of Brixadi. We will tend to use Sublocade for them. The Sublocade comes in 2 doses. There's a 100 milligram dose and a 300 milligram dose. I'm forgetting offhand the dose equivalent of the 100 milligram, but it's something closer to the 128 of Brixadi. I'm looking to Damian. 24. The 100 milligram Sublocade is like 24 milligrams of sublingual Brixadi. The thing I use the most often is a 300 milligram Sublocade dose, which gives people a serum equivalent in the like 40s or 50 milligram of sublingual bupe, much higher than they're getting with the standard sublingual doses we use, especially if they're taking 300 milligrams of Sublocade every month. And so for folks who have a higher tolerance, I give them a 24 very commonly, I would say probably the most common regimen I do for someone who uses a gram of fentanyl a day, which is something like what most of my patients use, is I give them 24 milligrams of Brixadi on the first day, and then the second day I give them 300 milligrams of Sublocade. And that works well for people with a high tolerance. Are there other questions? Okay. All right, I'm gonna turn it to Leslie.
Okay, and we will have more time for questions after the presentation. So if people have questions about anything or even just anything related to buprenorphine, feel free to stick around and we will be happy to answer them. And so for the last part of this talk, we were lucky enough to receive a fellowship from PARC, where we sought to evaluate the outcomes associated with direct-to-inject protocols, particularly for people with and without chronic pain. In our setting, as we mentioned in the safety net system, we do see a lot more patients with opioid use disorder. So, but a lot of people, as we know, also are living with chronic pain. And so we wanted to see how do outcomes differ between various populations in our setting. The background on this is that we know that the literature is very sparse when it comes to direct-to-inject initiation using injectable buprenorphine for people with OUD or opioid use disorder, especially among people with chronic pain. It's basically not been studied between pain outcomes for people who've undergone direct-to-inject. And then also, even more surprising, a lot of research has not yet been done on patients who are on long-acting injectables. What are their actual pain outcomes? And so that was one of the those were the sort of goals of our Be in Step project or fellowship. Be in Step stands for buprenorphine injection for safety net treatment of pain and addiction. So Sarah was very kind enough to put together this literature review of all of the papers that have been published on direct-to-inject. And as you can see, there are 5. So there is not a lot of literature out there. And all of these papers are really focused on patients with opioid use disorder and just even the feasibility of doing direct-to-inject in a real world setting. And so when we think about buprenorphine and chronic pain, what we know is that if you look at patients with opioid use disorder across the board, about half of them will have chronic pain. We know that the overlap of chronic pain and opioid use disorder is especially hard to treat because there's a lot of psychosocial factors, a lot of pain factors, and a lot of just use disorder factors. And you're trying to treat all of them often with one medication in a very limited time setting, which can be very challenging for patients and clinicians and health settings. We know that buprenorphine is a really promising option because of its superior safety profile, its lower risk of overdose and misuse, and the fact that it can be effective for pain control among patients with chronic pain. As I mentioned earlier, the buprenorphine formulation, so the patches are FDA approved and do work for chronic pain. But for patients with opioid use disorder that have very, very high opioid tolerance, the equivalent buprenorphine doses for patches are often too low to actually get any adequate pain control. So the highest buprenorphine patch dose is 24 micrograms, and that's about the equivalent of 1 milligram sublingual, 1 to 2 milligrams sublingual per day. And so it's very, very low dose. We know that sublingual buprenorphine can provide higher doses. So oftentimes in clinic, if I have someone who has chronic pain but not opioid use disorder, we'll use a buprenorphine patch or very low dose sublingual buprenorphine. But again, it can be very, very challenging to really, if there's ongoing uncontrolled chronic pain, there's this question of whether injectable buprenorphine, which is a much higher dose of buprenorphine, could that actually treat their pain and treat someone's opioid use disorder because it's a more consistent dosing It's less, ups and downs that you would have with the sublingual doses. You can offer higher therapeutic concentrations in the serum, and then it's a longer duration of protection from overdose, which again portends that higher safety profile. So our aims for the grant were really twofold initially, and then we added a third aim. So first to compare treatment retention among people who have started buprenorphine using direct-to-inject, and then also stratifying them with or without chronic pain to see, is retention actually better among patients with opioid use disorder with or without chronic pain? And then also we wanted to really look at their chronic pain scores among people with chronic pain in OUD to see, if they are receiving chronic or ongoing injectable buprenorphine treatment, does their pain scores actually improve over time? And then we also added qualitative interviews with patients with opioid use disorder who and with or without chronic pain who have recently undergone direct to inject to see, what their experiences are and to really capture that perspective because it has not yet been done. For the first two aims, we are doing an observational cohort study using mostly through chart review of patients throughout the entire health system. Our population are patients with OUD, starting buprenorphine via direct-to-inject. And we have about 300 patients over the past 9 months that we've already been able to gather data on, and about half of them have comorbid chronic pain. We worked with clinical documentation through various sites. Sarah, do you remember how many clinics we have? 11 clinical sites, which is quite impressive and is a testament to how hard Sarah has been working on partnering with all these clinics. And we asked all of these clinical sites to use the same documentation of how, when they do direct to inject, to document whether that patient has chronic pain, what their ongoing pain scores are at each visit, and then also various other measures that we then abstract later in the chart. And so we include demographics, their opioid use history, COW scores or their clinical opioid withdrawal scores, their treatment retention at 30, 60, and 90 days to really get at that first aim. And then we use PEG scores, which are pain evaluation scores, to really track how people are doing with their chronic pain, if they're actually improving in their daily functioning from pain each follow-up visit while they're on the injectable buprenorphine. And then finally, we're aiming to do semi-structured interviews with patients to really understand their direct-to-inject experiences. And we've done, I want to say, 11 or 12 already. Yeah. So we're more than halfway there. And our grant ends in May, and so we're really close to being done with all of our data collection. So far, we have a sample size of about 324 patients in our cohort. And so, so it's 10 unique clinical sites. Yeah. And then it's a mean age of 42 years old. Most patients, again, are from our safety net. Or all patients are from our safety net. Most are white, about 21% are Black African American, and then 15% Hispanic Latino. There is a high rate of unstable housing status. So about 28% or a third of people have unstable housing. About half of them are unhoused. And so this is a population, again, with high rates of structural challenges in terms of socioeconomic status and social mobility. We do see that when we looked at our current cohort of 324 patients, again, the treatment retention seems to be about 61% of people continuing to be on buprenorphine. And then we look at patients specifically with chronic pain. It's a slightly higher retention, so 67%. And then also no chronic pain, about 85 people. It's about 49%, so lower retention. And then there's unknown pain status for 97 patients, and which is about the same as the entire cohort. And so we are seeing slightly improved outcomes for patients with chronic pain, but this is by no means a final analysis. We'll, of course, have to adjust for various confounders and you know, as particularly age, as patients who are older may have better treatment retention and are more likely to have pain. But I think that these early results are a little bit promising, and but again, unclear if this is actually, you know, statistically or clinically significant. So finally, our next steps are we'll be evaluating our pain scores throughout our entire cohorts and then completing our interviews and qualitative analyses to really get a sense of what our patients' experiences with this whole process. And thank you so much. And we will open up the floor for questions. Thank you. Okay. All right. So now I can see the chat. Let's see. So I think we answered the question from Samantha. And then Lori Resner had a comment. Buprenorphine commonly used for acute and postoperative pain by veterinarians. That is true. I have used buprenorphine for my cat after he had a broken leg. And so that is a very true statement. And Marilyn said that buprenorphine is used more broadly in European countries for treatment of acute and chronic pain. I do think that there is, you know, an increasing interest in using buprenorphine for acute pain. Again, I don't know that it is, I haven't seen any, you know, robust clinical trials on this yet, but I do think that there's more literature coming on this down the pipeline. And as I know, you know, buprenorphine is considered a safer opioid with lower misuse potential, lower overdose risks, and a lot of potential for acute pain treatment. And, you know, I am very interested to see where that literature goes. Any other questions?
I have a question.
Yeah.
If I unmute, is it gonna do feedback?
No, I don't think so.
Okay, since you mentioned robust clinical trials, what do you all think are next directions for the research, whether it's basic pharmacokinetic or clinical studies to lead us forward?
I'd be curious to hear. Oh, sorry. Yeah. Damian, Sarah, I am in brain fog mode, so I'm curious to hear what you guys think.
I think there's a lot of different potential avenues for next steps in research. I think one of the things that would be really interesting, so I also work at a methadone clinic, an opioid treatment program. And in methadone clinic, we use serum levels of methadone to help us make clinical decisions about whether or not someone's dose is toxic, therapeutic, how fast they metabolize. There's a lot of information that we can gain about the way that someone processes methadone from serum levels of methadone. We have some tests that look at serum levels of bupe, and Damian could speak about this more than I can, but we don't have any validated uses for them or kind of ways to better understand variation in individual people's bupe metabolism. So one of the things that we're seeing in some early research and that we're seeing in our kind of clinical situation as well is that there are some patients who just do worse, and we don't totally know why, but some of them have severe withdrawal much sooner than the buprenorphine peaks or should peak in average populations. And so we wonder, in the same way that we have people who are rapid methadone metabolizers, do we have people who are rapid bupe metabolizers? And actually they're experiencing something closer to the like high serum levels you get with sublingual bupe soon after their injection, and that's why they're doing poorly. That would be useful to know. We know nothing about the different genetic, genomic, whatever profiles of people and how they respond to buprenorphine, and that could be really useful to know. So there's a lot of basic science work to be done about which we know very little. I think there's also a huge need for prospective research in this area. You know, we have that one prospective emergency department trial that has a lot of confounders and is quite complicated in a lot of ways because it was a study looking at buprenorphine initiation in a population with a lot of baseline buprenorphine exposure, and so wasn't necessarily studying de novo initiations. And I think we have a lot more prospective work that needs to be done, and RCTs, of course, to better understand this. I think there's epidemiological studies that would be really useful too. Those are the things that come to mind immediately. Damian, anything you want to add? You have to talk to the thing.
Yeah, I think kind of to Sarah's point about we do have this group of people that just kind of do really poorly and we don't have any explanation why. I'm really curious about that. Probably a bias because that's more the like pharmacokinetic aspect, but in the company's internal data, they have like, we know the average peak time with these weekly injections is 24 hours, but for something like close to 20% of people, they have peaks that are like less than 12 hours. And we just don't really understand that, but is possibly a reason why some of our patients have a bad experience. So I would love to have like a better understanding of why this difference exists so we can either plan for it or find how to avoid it.
Another thing that we've been talking with that I just remember that we've been talking with colleagues around the country about is why we're seeing really different experiences in some parts of the country than others with regards to tolerability of direct-to-inject buprenorphine initiation. So we have colleagues in Wyoming who we've been talking with who basically like never see much withdrawal. And we wonder whether our higher prevalence of stimulant use disorder, the amount of meth that people use here relative to their plays into that at all. We wonder about other comorbid substance use disorders, especially. We know that there's really widely different patterns of drug use and drug exposure in different parts of the country. And so, our work, the emergency department trial was national. It was at 4 large emergency rooms across the country. But the outpatient work has all been done sort of in Seattle and the Bay Area mostly. And so that's a different patient population than perhaps the drugs we were seeing elsewhere in the country. So I think there's a lot of sort of variability work to be done. And then the last thing I'd say is I think there's a lot of room in kind of the implementation science world to better understand how to sort of roll this out more practically. The biggest barrier that we faced in implementing this more broadly has been logistical, has been like buy and bill agreements with Medicaid and how pharmacy, like the injectable medicine is a benefit that insurance covers and Medicaid covers, but the logistics of actually getting it paid for so that we have it on hand and can give someone this treatment the day they walk into care and don't have to say, oh, come back in 3 days when we can get the medicine, has been really one of our most complicated barriers. And so I think there's a lot of like implementation work to be done there as well. Other questions? Why don't I just repeat them so that you don't hear the echo? Okay.
So one, you sort of brought this up, but maybe you can expand on it a little bit. Do you see any patterns yet or anticipate any patterns for outcomes related and whether or not people have been taking meth?
Okay, so the first question was about whether we see patterns for people who use meth. Anecdotally, in our data, no. No statistical analyses done yet, but just looking at the numbers of retention and withdrawal outcomes for people who use meth and don't use meth in our population of this 320 something that we have so far, no major differences. But I think there's a lot more to learn there. And I think we don't know yet. You had another question.
Oh, actually, can I add to that? I think it's really hard to study that in our population in San Francisco because meth and fentanyl are the Venn diagram is a circle. So, when we recently did a serum study of about 100 patients who presented for methadone treatment, all using fentanyl. And when we actually looked at their serum levels, everybody was positive for meth. Even though they might not report using meth, their body had it. And so it's really hard. I mean, there's no way to stratify the effect of meth with or without when everybody is positive for meth in their body. And so I almost, to Sarah's point, I think we do need larger populations where in San Francisco, it's just impossible because everybody has meth in their system, whether it's contamination, intentional use, we have no idea, but fentanyl and meth just run so closely together in San Francisco.
Part of the reason I ask is we do basic science, so we just choose what we're giving the animals. So maybe we should think about it. We should.
It's a really good question. In this study, what we have done, the way that we've tried to assess for presence of regular meth use, we thought a lot about different ways to assess it. Like, should we look at the chart to see if they have methamphetamine use disorder listed as a problem or in a urine drug screen? But people chart clinically in variable ways, and urine drug screens are often not available for a lot of our patients. Is part of our kind of standard documentation is for clinicians to ask patients, are there any other substances you've used in the last week other than fentanyl? And then they'll write down meth or nothing or tobacco or whatever. With the major caveat that one of the, Leslie highlighted a slide that shows a chunk of our patients we have no chronic pain data on. Those are patients for whom we don't have PEG scores available because this is a retrospective study where we've sort of asked our colleagues to roll out this clinical documentation, and people have done that with variable success at different clinics. And so there are some people for whom we don't have that kind of standard information available.
My second question is, again, as a basic scientist, if I was going to design an experiment where I made animals dependent on an opioid and then, tested what are the effects of buprenorphine, like with different, reduced kinds of approaches, what would you recommend that we look at as the opioid to make the animals dependent?
Oh, that's such a good question. I have no idea, which is why I'm backing up.
Yeah, and then answer your dog. Put you on the spot. You repeat the question.
All right, so the question was if you were to design a study comparing the effects of like buprenorphine on an animal that is dependent on an opioid, which opioid should we?
Which opioid should we make the animal dependent
on? Well, I mean, fentanyl's the predominant opioid that we see here. So that would be my best guess.
Would you need to like have a? I'm just thinking about the kind of the variable, like the different fentanyl effects we get over time versus like you need them to be exposed to fentanyl over like long enough that they have the like lipophilicity and all that stuff too, right?
Yeah, and I also don't know which animal models would maybe most similarly replicate like the fat distribution that we have in humans. So yeah.
It's a cool question.
I think that's a wonderful question. And I think it's also the most important part of that question is the dependence piece, because it's not just recent exposure to fentanyl, it's the dependence itself, and reaching that lipophilicity, like we mentioned. Alex is also part, or Alex Bazazzi, sorry, is also part of a study where we're looking at the chronicity of fentanyl exposure, and if someone doesn't have the downstream markers, is that a marker for chronic, how do we measure chronic use in patients? That can be another question, is just like, in clinical medicine, we only have urine drug screens that are positive or not positive for fentanyl. So are there other sort of downstream isotopes or opioids, metabolites that we can check that are actually more significant or actually show chronic use as opposed to recent exposure? That would be super, super helpful. Okay.
Yeah.
All right. I think that is all the questions that we have. We're happy to end early or stick around if other people have questions, especially clinical cases that people want to discuss. We're also happy to chat. But thank you everybody for attending.